All right, so let's move on to the second part of renal exchange. So that was the first process, or the first renal exchange process, which is filtration. So we're going to move on to speak about reabsorption, which gets us into how do we fine tune that filtrate going forward. So we're now looking at so someone's asking me to go over mesangial contraction. So we didn't talk a whole lot about the mechanism of mesangial contraction, but essentially these are the cells that are nestled in between here. They can detect the contraction or relaxation of the afferent arteriole because of their location, their location in between those vessels. If they detect an increase in stretch, they're going to send signals to the afferent arteriole cells, and they'll bring about that same response. And an increase in stretch causes them to contract and to decrease that fluid or flow rate coming in, which will decrease GFR. Okay, so we've got different cells located in this complex that are all helping to bring about the same result. The macular densa cells are part of the DCT, sending signals to the afferent arteriole cells. The mesangial cells that are sort of tucked in between here, sending signals to the afferent arteriole cells, and then the afferent arteriole cells themselves responding to any increase in stretch as well. Okay. All right, I hope that sort of cleared that up there. All right, so we're now getting into how we fine tune our filtrate. So essentially the filtrate is now sitting in the first part of our tubular. After we filtered it across the filtration membrane, it's now sitting in the peritubular space. We now have to start reclaiming things that are useful that have been filtered across. And so this is the first part of fine-tuning that filtrate that eventually becomes urine. And so in order to do that, we have to move those substances from the lumen of the tubular structure of the proximal tubule across into the peritubular capillaries. And most of that occurs in the proximal tubule. Most of that is not regulated or unregulated in the proximal tubule. And just to clarify here, when we say unregulated or not regulated, we mean that this is happening freely. There's no hormone that is influencing this. Whether your dehydration state, right, how much fluid intake does not influence this. This is happening freely and fully, and it is not being regulated by any external influence. And so just to take a look at what some of that looks like here. So water, for example, is filtered at 180 liters per day. It is reabsorbed about 178.5 liters per day, so about 99% of that water is reabsorbed, and about 1% or so is what we lose as urine. So really important in maintaining our hydration state here. Glucose, again, is freely filtered across the glomerulus, fully reabsorbed, so 100% of that glucose should be reabsorbed back into the blood. And we should not see glucose in the urine, okay? This is a bit of a side story here, but this is how we used to diagnose diabetes in the olden days. The older physiologists, they would actually taste the urine of patients, and this is where we get that diabetes mellitus from. The word mellitus actually means sweet, and if there was glucose spilling into the urine because it was excess in the plasma, so there were high concentrations of glucose, it would start to be spilled into the urine. We'll talk about the mechanism of that coming up, but then this would allow the urine to be very sweet. And so this is how we would diagnose those patients as being diabetic. And so we should never, under normal circumstances, have glucose in the urine. It should be fully reabsorbed 100%. Urea is something that's also reabsorbed partially. So we filter about 933 millimoles, we reabsorb about half of that, and then we see about 50% of that in the urine. And then our other important ions are aggressively reabsorbed. So sodium, potassium, et cetera, et cetera. These are aggressively reabsorbed. They're really important in maintaining our ion plasma concentration. Things like sodium and potassium are needed for the sodium-potassium pump, for establishing the resting membrane potential, for calcium is needed for muscle contraction, smooth muscle, cardiac muscle. And so we don't want to lose these ions at all in any significant quantity in the urine. And so they are aggressively reabsorbed across the tubules. Okay, so getting into the mechanism of how we bring about this reabsorption. So most of the reabsorption happens in the proximal tubule. Some of it happens in the distal tubule. That's more regulated. We'll talk about that as well. And we want to introduce the barriers across which these substances need to be reabsorbed. So what are the barriers for reabsorption across these tubular structures? It's going to be the epithelial cell of the renal tubule, as well as the endothelial cell of the peritubular capillary. So thinking about this relationship here that we've described or established before, where the tubular structures are closely intertwined with these peritubular capillaries, and that facilitates that reabsorption of the important things that we need from the lumen of the tubule back into the vessel, back into the peritubular capillary. And so to look more closely at the barriers for what are the structures that these substances have to move across in order to be reabsorbed. So they're going from the lumen where they are sitting. So they're sitting in the lumen here. They have to go across the apical surface of the tubular epithelial cell. They then have to go across the basal surface of that tubular epithelial cell. They have to go across the basement membrane to the underlying connective tissue of that epithelial layer. They have to go across the peritubular space, so there's a small amount of interstitial space sitting between the tubular structure and the capillary. And then finally, they have to go across the capillary endothelial layer here, and then they enter the blood. So these are the layers. So it's really important for us to understand these layers here. We've got the epithelial cell, we've got the basement membrane of that epithelial cell, we've got the peritubular space, and then we've got the capillary endothelial cell layer. All right, now as far as reabsorption, we're returning most of our filtered molecules from the tubular space to the blood. So that's what's happening. Most of that is water, as we just established. We reabsorb about 178 or so liters of our filtered water per day. We reabsorb or reclaim, and about 1 to 2 liters of that is excreted as urine. This will increase in well-hydrated states, and this will decrease in dehydrated states. And I'm sure we've all experienced this. If you're well-hydrated, if you're drinking a lot of water, you're going to be urinating more frequently. Not only are you going to be producing more volume of urine, but the urine is also going to appear clearer, right? A clearer liquid that is more diluted as a result of that increased water reabsorption. If you're not drinking as much water, if you're dehydrated, you're going to be urinating a smaller volume of water. So less water, less than this 1 to 2 liters, certainly. And then that is going to be more cloudy, darker in appearance as it's more concentrated, because again, most of that is being reabsorbed as your body needs most of that water. Now, there is a minimum amount of water that must be lost every day in order to rid the body of waste. This is called the obligatory water loss. So even if you're bringing in 0 water intake, right, you don't drink water, which is really unhealthy, you still have to lose 400 milliliters of fluid every day in order for you to lose essential waste items that are starting to build up in the body. In other words, in order to prevent toxemia or any type of buildup of waste in the blood, you have to lose 400 milliliters of fluid, whether your body is bringing that in as fluid intake or not, okay? 85% of that reabsorption is happening in the proximal tubule and the descending loop of the limb of Henle. So this is unregulated reabsorption of water. We're going to talk about regulated reabsorption of water in the distal tubule by another mechanism later on, but most of where we absorb water is via the proximal tubule, as well as the descending limb of the loop of Henle. So 2 different mechanisms, but they're both unregulated and they're both responsible for most of our water reabsorption. Okay. Now, the osmolality of our filtrate is equal to the blood concentration, right? These 2 such solutions here are considered isoosmotic. And when we say osmolality, this may confuse some students. It's the same idea as osmolarity, right? Just a different word here. And it's basically the same thing for our purposes. It's just using a different unit for the total solute concentration. So whereas osmolarity is the amount of solute dissolved in a liter of solution, osmolality is the amount of solute dissolved in a kilogram of solution. So same idea, it's basically the number or amount of solute concentration. And so the total solute particles in our lumen solute, so the amount of, the filtrate sitting in our lumen rather, is the exact same as our plasma. So these two solutions are considered isoosmotic to start, okay? And so in order for us to move anything from the lumen of our tubule across these three structures we identified and into the paratubular capillary, we're gonna have to set up these solute gradients. So we're gonna have to actively pump some solutes that can create a gradient for us to passively allow water to follow, okay? And so we'll talk about how we set up those concentration gradients in order to drive osmosis where water can simply follow. Now, the cells that are lining the proximal tubule are joined by these tight junctions, right? So the apical surface of these cells faces the lumen. We've also got these leaky tight junctions, and these are going to allow for some paracellular transport. In other words, there's not a super tight junction between this cell and this cell at these junctions. And so some things are going to be able to slide right through the sides of these cells. So that's kind of one way that this is unregulated as well. Now, the apical surface also has what are called microvilli. And microvilli are these modifications, pretty much these foldings of the membrane, and they help to increase the surface area so that we can have more room, more space for absorption to occur. So those are just two modifications of the cells of these proximal tubule that help us increase the amount of absorption across this membrane, those leaky tight junctions, as well as those microvilli at the apical surface. Now, to start, the cells have a lower concentration of sodium on this side than there is inside the cell. So essentially, there's more sodium being pumped out of the cell. So if we think about the structure at the basolateral membrane here, we've got the sodium-potassium pump, and that is pumping sodium out. So, right, 2 potassium in, 3 sodium out, if we remember that pump. And so we start to develop the situation where there's less sodium inside the cell and more sodium in our filtrate, right? And so solute Y is representing that sodium here. So we can passively move sodium, or solute Y, into our cell according to its passive concentration gradient because it is being actively pumped across the basolateral membrane, okay? And so that's how we get solute Y, mainly representing sodium, across our apical surface. Now, because we're pumping solute Y, and because we have some energy liberated here from the passive movement of solute Y across the apical surface, we can now use that energy to bring another molecule across the surface as well. Anyone remember what mechanism of transport that's called? So what mechanism uses the passive energy liberated by one ion movement or one molecule moving and moves another molecule against its concentration gradient? Excellent, thank you. So secondary active transport, that's perfectly correct. So this is another mechanism of active transport, but this one is where we take the energy that's needed from another ion that is moving passively. So things like chloride can move actively by liberating the energy of sodium moving. Another molecule that could be represented here with solute X is glucose. Glucose also moves into the cell by the energy that sodium liberates. And so different ions and molecules can be actively transported across the apical surface using that energy that sodium is liberating, passively moving into the cell. And then solute X, which can be chloride or glucose, is going to move across the basolateral surface via facilitated diffusion. And so if you remember, facilitated diffusion was a passive means of transport. So we're moving according to a gradient. And we've now built up this gradient. We have a higher concentration of solute X here. We've got a lower concentration out in the paratubular capillary. And so we can move that ion passively, but we're still going to need some type of carrier here. Okay, this is indicated on this basolateral surface. And so we've got 3 different mechanisms that we're using to create this solute gradient. We're actively pumping primary active transport with the sodium-potassium pump, actively pumping sodium out of the basolateral membrane. That's one mechanism. We're moving sodium in passively, and we're taking other ions and molecules for a ride. So that's secondary active transport. We're bringing in things like glucose or chloride actively with the energy that sodium is liberating. And then the third mechanism is facilitated diffusion. So those ions that are now building up, or molecules, glucose being an example, that are building up in their concentration inside the cell can move passively across the basolateral membrane via a transporter or carrier according to facilitated diffusion. Okay. Now, after we've done all of that, so we've moved these solutes and molecules over into the paratubular capillary via these three mechanisms, we now create a water gradient. So we have more solutes over here in the capillary, less solutes behind in the tubular fluid in the lumen, right, that filtrate there. And so we now have an osmotic gradient. We have a gradient where water can freely move from its area of high water concentration, in other words, low solute concentration, all the way across these barriers to an area of high solute concentration, in other words, low water concentration. And so that creates this osmotic pull where we can absorb water according to osmosis. Okay. At the bottom here, we can see some other substances that are freely moving according to simple diffusion. So no carriers, no transporters, no energy required. If we have a higher concentration gradient of these substances behind, which is naturally the case. As we remove most of that water, the solutes can eventually have a higher concentration on this side. And as we put more of that water on this side, there's going to be a lower solute concentration over there as well. So smaller, non-polar, non-charged substances that can easily move through our cell membranes can just simply follow via simple diffusion. All right, so those are the main mechanisms by which we reabsorb most of those important and useful substances. And so just to recap or summarize that here, we've got chloride being passively transported across the basolateral surface. Remember, this was facilitated diffusion. Sodium being actively transported across the basolateral surface. This was primary active transport via the sodium-potassium pump. And then water simply following by osmosis.